অনেক সময় মানুষে পয়লা বৈশাখী উৎসব পালন করে। বছরের প্রথম মাস ঢুকছে, তখন অন্য মানুষে দেই ঘুরতে যায়, নতুন জামা কাপড় পরে। আমরা আগের মতোই দিন যাপন করি, পোলাপান সামলাই, ঘরের কাজ কাম করি। আমাদের ওইরকম কিছুই না, আমরা আমাদের মতোই দিন কাটাই। আমরা বছরের প্রথম যে সময় সারা বছর যেরকম ভাবে চলি, ওইরকম ভাবেই আমরা বছরের প্রথম পালন করি পয়লা বৈশাখ। এমএমএস তো আমি যখন ডাক্তারের কাছে গেছি তখন আলট্রাসাউন্ড করছি। 4 মাস প্রেগনেন্ট যখন, তখন থেকে আমি এমএমএস নিতেছি, নিয়ে খাইতেছি। তখন ওর থেকে আমি খাওয়া ধরছি, আমার কোনো সমস্যা হয় না। আমার টাকাটা আলাদা করে রাখতে হয়, বাঁচাইতে হয়, তো আমি রাখবো। খাইলে আমার বাচ্চার ভবিষ্যতের লাগে ভালো।
জান্নারা যখন এই কাজটা করতেছে 7 মাসের পেটে, গার্মেন্টস করে, জামাই চাকরি নাই, তখন হয়তো অনেক কঠিন। যে সময় আমরা কিছু সাহায্য করি, দরকার হইলে আমরা নান্দা বান্দা করে দিই। চলাফেরা কষ্ট, চলাফেরা চালাইতে একটু যখন চাকরিটা করে তে সহযোগিতার একটু জাহানারা চাকরিটা করাতে তাহার সংসারটা চলতেছে।
হয়তো গার্মেন্টসে সকালে যাই 8টা বাজে, যে অনেক সময় দেখা গেল যে কাজের শিপমেন্ট হয় এক জায়গায় একটা না, ধরতে গেলে যে সকাল 8টা থেকে 5টা পর্যন্ত 8 ঘন্টা বসে তাহলে। আমি কাজের চাপে অনেক সময় পানিও উঠে খাইতে পারি না। অনেক সময় কাজের চাপ কম থাকলে দেখা গেল যে আমি একটা বিস্কিট খাইয়া একটু পানি খাইলাম। হ্যাঁ, ওদেরও তো সুযোগ সুবিধা থাকে, তো সবসময় তো আমগো সুবিধা দেখবো এটা তো কথা না, তো কোম্পানি চালায়। খাবার এই যে সকালবেলা উঠি, ওইটা ভাত রান্না করি, হয়তো সময় থাকে না, অনেকদিন না খাই এই জায়গা, আবার অনেকদিন দেখা গেল যে অল্প কটা ভাত খাইয়া পানি খাইয়া গেলাম। তখন না খেলে তো আমার শরীর দুর্বল হয়ে যায়, তখন কাজ করতে পারি না। ওই সুপারভাইজাররা চিল্লাচিল্লি করে। গল্পটা খালি আমার একার না, আরো হাজার হাজার মেয়েরা আছে যে আমার মতন, আরো অনেকেই চাকরি করে, অনেকের এই গল্প এরকম আছে। আমি শুধু একজন গার্মেন্টস কর্মী না, আমি এর চেয়ে আরো বেশি কিছু। আমি একজন মা।
আমার মা পরিবারের জন্য সবকিছু করে, আমাদের মাই সব। আমার মাকে নিয়ে আমাদের জগৎ, আমার মা রানী।
Wow, what an interesting but also sobering story about Jahanara from Bangladesh. In case you joined us when the movie was already in progress, feel free to go back to our YouTube channel and you can watch that film. It's in our series called Women's Voices Short Films. You will also find other women's voices films there from, for example, the DR Congo, the DRC, Ethiopia, India, etc. I want to take this opportunity to welcome all of us to this Healthy Mothers, Healthy Babies third coffee and chai chat, or other webinar as other knows them. of this year. The topic today is an enabling environment for multiple micronutrient supplements, lessons from Bangladesh. Today's chat will dive deep into the recently released case study by the Healthy Mothers, Healthy Babies Consortium. We have, in the last 1 year, almost 1 year and a half, been working very closely with our Bangladeshi colleagues and experts to document the story of Bangladesh, which we hope to share with you today. We are pleased to welcome an almost honorary, quote unquote, honorary Bangladeshi, Professor Keith West, who will host today's chat. We think this is the most appropriate person to do this. He is the George G. Graham Professor of Infant and Child Nutrition, Department of International Health, Johns Hopkins Bloomberg School of Public Health in Baltimore, Maryland. And he's also the Vice President-elect of the American Society for Nutrition. We also welcome 3 experts who will present today the case study and answer your questions. Ahmed Shamim, Associate Scientist, Center for Non-Communicable Diseases and Nutrition, Brack James P. Grant School of Public Health, Brack University, Dhaka, Bangladesh. Tareq Hasan, who is a project manager in charge of MMS at GAIN, Bangladesh, Global Alliance for Improved Nutrition, and Nilima Azad, the Monitoring and Improvement Coordinator of the MMS program in GAIN, Bangladesh. Experts Mahbubur Rashid, Ruhul Amin, and Sneha Sarwal, who also worked on this case study, will also join the discussion. Now, to learn more about the HMHP, which is hosted by the Micronutrient Forum, you can visit our website at www.hmhpconsortium.org. And I want to take this opportunity to give you some short housekeeping instructions. First, feel free to introduce yourself with your name, organization, and country in the chat. And please write your name and affiliation in your Zoom window and turn on your video. All participants will be muted during the presentation, but will be able to unmute themselves during the question and answer session. Use the raise your hand feature if you'd like to ask a question. You are also welcome to use the chat box to ask questions. In case you have any technical difficulties, just send a direct message to tech support and you will be assisted. And kindly note, this meeting is being recorded and the recording will be available and distributed later through the consortium website /coffee and chai chats. You'll also get the presentation perhaps later. At this stage, I want to hand over to Professor Keith West to start the session. Oh, Professor Keith West, you are muted, yeah. and I will perhaps take this opportunity to say my name is Martin Mwangi and I am the program lead of the Healthy Mothers, Healthy Babies Consortium. Over to you, Professor West. Again, you're muted. You might want to click the unmute.
I'll try this again. This is a coffee and chai chat, so please have your coffee in hand. We are here today to, talk about an extremely important intervention that has developed evidence over the past 20 years to improve an aspect of nutrition of women during pregnancy and improve the outcomes of those pregnancies. And Bangladesh has been truly a leader in this area in terms of pushing this program forward. We're looking forward to the speakers to hear about an update of what is going on, and then to move into some discussions around the implementation of MMS as a strategy that needs to be scaled up, where undernutrition remains a problem in Bangladesh and elsewhere in the world. So we're looking forward very much to this discussion. Would you like me to introduce the speakers, I think, Martin, or is that Rijuta?
So I had quickly introduced them. Perhaps we can go now into the presentations.
Yes. Who goes first? Shamim. Okay, very good. I'd like to ask Abu Ahmed Shamim to give a presentation. Shamim has been a pioneer in nutrition research for decades, 2 decades now or more. So please, Shamim, proceed.
Good afternoon. Okay, actually the first 2-3 slides will be presented by Nilima. I am asking Nilima to present.
Okay. Thank you, Shamim Bhai, and thank you, Dr. Keith. Good evening from Bangladesh. Hello, everyone. I'm Nilima, joining from GAIL Bangladesh office. Thank you, Keith, for the opportunity to present the case study on creating an enabling policy environment on maternal nutrition, lessons from Bangladesh. Next slide, please. Next slide. Okay, thank you. Before diving into the insights that has been gained through this case study, let's take a moment to revisit the journey of malnutrition, micronutrient supplementation in Bangladesh. Like in 2007, the malnutrition rate among under 5 children was quite high. The stunting rate was 43%. And the micronutrient survey in 2011 and 12 also highlighted that prevalence of micronutrient deficiency in this age group is also high. So during this period, GAIN, in collaboration with BRAC, launched the Infant and Young Child Nutrition (IYCN) program in Bangladesh. And from 2007 to 2010, the program supported improvements in IYCA practice and promoted the effective use of home fortification with micronutrient powder, MNP. So with the lesson learned from this phase 1 of MNP, the phase 2 of market-based model MNP started, which was supported by C. And the collaboration was between GAIN, BRAC, and SMC, implemented the program in Bangladesh. The government also piloted a Pro-4 model during this time. So from 2013 to 18, this MNP project became the largest commercial model globally, with over sales of 145 million sachets during this time. So after the success of MNP, in the meantime, in 2015, the National Low Birth Weight Survey in Bangladesh projected high low birth rate in Bangladesh, which was 23%. And in 2016, the National Anemia Consultation also showed that micronutrient deficiencies among pregnant women is also contributing maternal anemia, poor health, and adverse pregnancy outcome. So this led to pilot a program to test the acceptability of multiple micronutrient supplementation, MMS, which has been implemented. The pilot was implemented by SMC's market-based model. And in the meantime, studies in Bangladesh like the GBT trial also demonstrated the positive impact of MMS during pregnancy on birth outcomes. So considering all this, the positive impact of MMS as well as the burden of micronutrient deficiency, maternal health, Bangladesh government also showed interest to demonstrate 2 types of model in Bangladesh, one through public ANC platform and another through private market-based model. So from 2019 till now, CIF has invested in the market-based model of MMS delivery, which has been done by SMC, GAIN, and Site and Life. Next slide, please. Okay. So the objective of the Pro-4 model in Bangladesh was to distribute MMS through public antenatal care service platform, which has been piloted in 2 districts, that is Bhola and Kurigram. And the key outcomes included that MMS coverage was in intervention area was 90%, and in control area, the IFA coverage was 52%. And the adherence, 180 tablet has been received for the intervention area was 30%, and in the control area, IFA was received by 12%, which you can see in the adherence was 43% higher in the intervention area compared to IFA in the control area. And also this MMS intervention also helped to increase the ANC, 4+ ANC in the intervention area, like 37% mother was attending the ANC, which was 23 earlier. So that's from my side. I will over to you, Tareq.
So we are actually from the GAIN, SMC, Site and Life with the support from the CIF. We are actually implementing the market-based private sector model in Bangladesh. So the objective of this project is to establish a sustainable business model for MMS for the pregnant women in Bangladesh. It is actually delivered through the pharmacy network in Bangladesh. So key outcomes, what I can say that we are able to produce locally quality MMS. That is the main achievement of our project, that we are able to produce locally quality full MMS through our project. And another great achievement, what I can say that we are able to sold almost 62.7 million tablets. The tablet sold was started from July 2021, and we are approximately reached 700K pregnant women through our project. It's the update up to the July. So MMS price, if you consider the MMS price, it's the per tablet cost is 4 taka, that is Bangladeshi 4 taka is 0.04 USD per tablet, and the full course of 180 tablet will cost 720 BDT or around $8. And so far our observation from the consumers' behavior and purchase pattern, we found that the average pregnant woman is purchasing 8.8 or equivalent to 9 blister from the market, and less than 90 tablet purchase is 51%. Greater than or equal to 90 purchase tablet is 28%, and purchased 180 tablet during pregnancy is 21%. So key insights from the both model, what I can say that we found that the compared to IFA, the acceptability and adherence is for MMS is significantly high, what I can say, and very less complaint from the consumer side, because from the SMC side we constantly keep in contact with the pregnant mother who are actually purchasing from the pharmacists to know their feeling, what are their experience after consuming MMS. So what I can say, the adherence is very good, which is also demonstrated in the public sector demonstration program. It's also we are also observing in the market-based model, and I think both approach demonstrated the feasibility. So next slide, please. So what I can say, the lesson learned from our market-based model is sustainable business plan is very important, because SMC is working in Bangladesh for a long time for the public health, for their public health products. So SMC is a very well-known brand. So any public health product actually takes some time for the market maturation. So like the MNP and the other contraceptive products from the SMC, it takes almost 10 to 15 years. So MMS from the SMC is on the market for last 3 years only. So we think, and the sales volume, you see that we think that within 8 to 10 years, MMS from the SMC will be the #1 brand for the pregnancy supplement in Bangladesh. So for the market maturation, actually it takes time. That's one lesson we learned from the project. And another learning is that the diversifying the distribution. SMC has a strong franchise network throughout the country. It's approximately 15,000 franchise network, community volunteers, and different type of networks. So distribution channel is very important. So without distribution, without proper distribution channel, you can't make available the tablet for the pregnant women. So distribution channel is very important. And for our almost 5 years learning, we found that there is still the ANC checkup. The pregnant women are trusting based on the medical practitioner. So demand generation, awareness building among the graduate doctors, medical practitioners play a significant role in the sales and acceptance of the MMS tablet. We also observed that it would be best if there are several MMS brands available in the market following the uniform formulation, because if we consider the MMS or the multiple micronutrient supplement, there are many popular brands in Bangladesh available already, but none of them except our MMS product is following the uniform formulation. So uniform formulated MMS brands need to be promoted or produced by our local pharmacies, so that many brands can be available and customer can compare and pick their right brands. So holistic approach, we found that the MMS should be available from the public sector as well as the private sector, because people in Bangladesh are shifting the health-seeking behavior, especially the ANC behavior, from the public sector to private sector. So it's also important for considering the poor people who are living in the bottom of the pyramid. So for them, free distribution or public sector distribution is very important. So it should be available from the public sector as well as the private sector over the over the counter medicine. So from the business model, what we learned, so it's still the subsidized from the SIF general support, but at a certain point we need to make some small amount of margin to maintain the project cost, so that the business can be sustainable. So still there is we are not making any money from the project, but as a business model, as a sustainable model, might be you need to make a very tiny amount of margin so that you can maintain the project as a sustainable business model. So for the policy advocacy, actually we are jointly advocate for the MMS at the different stages, from the national level to global level to sub-district level, with the different committees, and we closely work with the government for including the MMS in the different policy and guidelines. We are also advocating to include the MMS in the essential medicine list and treatment guideline, and also we are trying to formatting the technical working group for the urban nutrition programming. So I am requesting Shamim bhai to continue the rest of the presentation.
Okay, next. So thank you, Tareq and Nilima. So I am describing the findings of a case study that was undertaken under the leadership of Dr. Mahabubur Rashid, and Professor Ruhul Amin and Sneha was with me. So goal of the study was to describe the process of formulating the policies and strategies for integrating antenatal multiple micronutrient supplementation in Bangladesh, describing the key events, process, and roles of various organizations, and also to identify and analyze the strategies, actions, and key factors that influence the process. Next. The method was, so we interviewed 15 key informants, except for kids, all of them were Bangladeshis. So those who were involved with research, with formulation of policies and implementation of the programs, and also reviewing documents, mostly grey literature. For example, the minutes of different meetings and national policies and programs, and we analyze data using standard process. So next. So this is the summary of the process that leads to adaptation of MMS in Bangladeshi policies and programs. So I am not describing all the events because it is given in the report, so you can download. So highlighting only few. So first, Bangladeshi evidence came in 2003 with the publication of the Minimed trial. But for various reasons, this result publication did not actually result in policy formulation in favor of providing multiple micronutrient instead of iron folic acid. And then GBR trial findings was published in 2014. It had actually huge impact on formulating the policies. One of the reasons was, after the publication of the result, there was active policy advocacy from the side of the researcher and also from program and various UN and international NGOs and government departments. Next slide. Next slide. Yes. So policy development, the 2020 publication of the interim guideline by the Global MMS Technical Advisory Group and the WHO publication of updated antenatal care recommendation have huge impact because generally in countries like Bangladesh, when a policy is proposed to be adopted by the Ministry of Health, they ask for international and local evidence and also ask for what WHO or UNICEF or other UN agencies recommend. So it had impact in favor of policy formulation and policy adaptation in favor of MS. Next slide. Yes. And in 2022, MMS was included in the National Nutrition Guideline published by the Ministry of Health, Bangladesh, UNICEF, and WHO. And also publication of the Site and Life Special Report and provision of funding from the pilot, which was conducted by Bangladesh government in 2 districts and selected sub-districts. This actually helped in favor of adaptation of MMS in Bangladeshi policies and program. So next slide. So if we summarize the enabling factors and catalytic event for inclusion of MMS in Bangladesh, so evidence from national and global MMS trials helped in formulating the policies and context specific frame around anemia and low birth weight. In Bangladesh, government was always interested in reducing the high prevalence of anemia, but because Bangladeshi people mostly drink groundwater, which contains lot of iron, and there were various research which reported that the enemy in Bangladesh is mostly in population who are not iron deficient. So there was a need for providing other micronutrient. It was believed that may improve the anemia situation because and then also low birth rate. Low birth rate was high in Bangladesh. So there was also because low birth rate is directly related to childhood undernutrition. So policymakers were always interested in doing something which can reduce the low birth rate. And the GBSA trial actually showed that multiple micronutrient compared to iron folic acid increased the birth rate. So it was one of the selling points. So and the evidence was generated from Bangladesh. And collaboration between researchers, policymakers, and international stakeholders was important. There was an informal forum in Bangladesh, Nutrition Working Group. It was not an official forum. It was a forum of various nutritionists from various national and international organizations. They met informally every month, and that actually played a very important role, including arranged a anemia consultation and technical and strategic support from National Technical Committee and Global MMS Technical Advisory Group was very important, and internal guideline. I already mentioned about the WHO updating guideline in favor of
Is Shamim bhai lost from the meeting?
What's the connection?
Yeah, I am back. So please,
Okay.
next slide. Can you hear me?
Yes, we can hear
Yes,
you.
yes.
Okay. So points of concern, the challenges in adopting the MS, there were several challenges.
I think we have lost Abu Ahmed Shamim again. Tareq, do you think you could, or one of your, or Professor Mabubor perhaps could continue until he, as Shamim reconnects?
Can you hear me now?
Yes.
Okay.
We should probably try to move quickly. Perhaps we could start.
Can you hear me?
The connection is not very
Hello?
strong.
Hello?
We can
Yes.
hear you, Shamim.
Hello?
Yes, we can get you. I can get you.
Can you hear me?
Sarwar, the connection is a bit weak. I would like to request Professor Keith to move to the discussion section as you look into your connection.
Sure.
And then
Okay.
we can, when it's stronger again, you can come back.
Sure. We can move to the discussion and probably weave some of these points in. We have such a vast array of experts around the table today and tonight. We want to move into some questions and issues. Just a few introductory comments that, MMS is giving us an opportunity to make a difference in pregnancy health and nutrition. It never takes the place of diet. At all. It is a dietary safety net that delivers a recommended dietary allowance of 15 nutrients, that those nutrients and their dosages are based on sound nutritional science. And the impact that this supplement has had is based on large randomized trials, and Bangladesh is really an example of moving from evidence to action. And the time that it requires to enable a country of this size and of such complexity in terms of the health system, public sector, private sector, that enablement time period can take on a different. It can be a different length of time, to be sure. And around the world, countries trying to move MMS forward are going to find their enablement time periods to vary according to circumstances, the health systems, and the challenges that they face. That we have a variety of issues to address. Implementation science is being put into action to evaluate programs in MMS programs, and there is a lot of work to do in terms of how to measure the implementation outcomes, how to validate those measures, and to report in standardized ways. So there's lots of issues to move forward with so that we can compare one country with the next. So a question for our speakers, in the pro-poor system that has been evaluated so far reports a 30% coverage in MMS and a far lower level in IFA. We do have a question about why is that so, and what can be done in the Bangladesh context for the public sector delivery system to move coverage up, and how is coverage being defined in this case? And I think I would ask any of our speakers, either Tareq, Nilima, or Shamim, to or Mahbub, to address that.
I think Tareq or Nilima from GAIN can better answer this question.
Okay.
Yes, actually, it was a small demonstration led by the UNICEF and National Nutrition Service in the 2 districts of Bangladesh, and 40 unions. The demonstration was, the sample size was 1,500 something. So based on the decision, the adherence they found that the good adherence compared to IFA, and also the consumption of 90 and 180 tablet was bit higher compared to IFA. And government, if you can say, the government moved towards the IFA. The National Nutrition Service operational plan for the next 5 years operational plan actually keep budget for purchase and scale up the MMS programming for the public health system, and they will do it gradually, not in a single shot of time. They will gradually add 3 crore to 5 crore tablet per year. So I'm not sure they are not actually targeting the pregnant women in their budget, but they're targeting the cost of the tablet procurement, tentative tablet number. And in the last technical working group meeting, the National Nutrition Service presentation from the National Nutrition Service, we know that they are targeting approximately 60% of the pregnant women by 2029 of Bangladesh. So that's the thing happening in the public sector in Bangladesh right now.
Thank you. Another question relates to blister packs versus bottle. And it's a highly relevant question. I'm working with UNRWA in the Palestine refugee camps. We're finding that the bottle, the 180 count bottle, is so much more straightforward to deliver and to validate approaches to assessing adherence. What's the experience in Bangladesh between those 2 physical forms of delivery, and can you list out some of the advantages or disadvantages?
So, Shamim, should I explain, or anyone from the panel?
You better.
So actually, in the demonstration program from the public health sector, they are also using the blister form. And from the market-based model, the full care, what we are working for the market-based model in Bangladesh, that is also in the blister form. Yes, we always heard that the bottle form and 180 tablet is more cheap compared to blister packing. But still, we are not implementing the bottle packing in Bangladesh, not even in the private and public, both type of demonstration. We are using the blister form because people in Bangladesh are more habituated in taking medicine from the blisters. Yes, there is a supplement bottle available in Bangladesh from the different companies in Bangladesh as well. But none of the supplements are actually more than 30 to 60 tablets, 1 month or 2 month maximum. We are not sure about what is the reason behind it. Might be the cost overlay issue is there, because purchasing 180 tablets or 60 or 90 tablets at a single time might hampers or create some burden for the consumers or purchasers who are going to purchase. So they like to purchase 10 tablets in a blister form, most of the cases. That's why in Bangladesh, the blister is more common among our community people. Or as also, that's why we are keeping the blister form. But in the next year, we have a plan to trial a small areas or small beneficiaries, how they react, how they react if we convert our blister into 30 or 60 tablet small bottles. So we also need to consider few things, that the humidity and the temperature in Bangladesh, especially the small pharmacies who preserve those MMS bottle in their shelf, they may not maintain the temperature of the bottle. So the quality might be the issue. We also need to consider those things. That's why in the next year, we have a plan to pilot very small scale to understand the reaction from the consumers as well as the tablet quality.
Thank you very much for that response. While asking questions, we would encourage those around the virtual table to please ask questions. We would benefit from your expertise and your insights because we have a lot of experience in our audience. Another question relates to the balance that can be struck between MMS as a prophylactic and how to incorporate it with the treatment of anemia, how to blend the treatment and prophylaxis together, and what has been the experience in Bangladesh with respect to sorting out that policy, that clinical protocol and policy. Anyone?
I think that was one of the issue. So for selling multiple micronutrient over iron folic acid, so anemia was a key issue, and so for the policy advocacy, there was emphasis was given that particularly in Bangladesh, anemia is especially in the rural area where people drink iron-rich drinking water, anemia is associated with deficiencies of other micronutrients. So I think it helped in adaptation of the program in favor of multiple micronutrients.
Very good. Thank you, Shamim. Another question relates to providing and assuring a national pipeline in the supply of supplements. And Bangladesh is going private sector and public sector, and it's critical that the supplies penetrate the markets of the poor, the clinic system, the health system, so that these supplements are available, affordable, and those are really important. How is the supply being assured in Bangladesh? Sounds like the private, the commercial approach is moving forward really well. How is the public sector supply chain moving forward? And can somebody address that?
Hello, Professor Keith. This is Dr. Mustafis, ex-Director, National Nutrition Services, now working as advisor to the GAIN. So
Very nice to see you.
I was very much involved with this public sector for about the 32 years. So what we have seen about this period, the anemia rate reduces not more than 10%. And only one approach was the single approach, and which was not enough to reduce the anemia of the country. So we have procured only IFA and only IFA over the decades and distributed throughout the country through the Central Medical Unit, CMSD, Central Medical Drug Unit. So it was distributed to the division, district, sub-district, and the union or the community clinic. And our health system is functional, more functional in the rural area than the urban area. Mm-hmm. And our mothers in this region, they usually don't believe about taking the medicine throughout the pregnancy. They take this as the secondary. And what we have procured for the targeted population, we have found only 100 tablet, less than 100 tablet was taken, and compliance was not good. So now we are in the transition mode. Same thing will happen for the MMS as well. The 780 or 800 BDT, it is less than $8. For whole pregnancy, the MMS or the or the other preparation by the SMC. So these all are in the transitional phase.
Mhm.
So we have to motivate our field level service provider, and they have not clear-cut idea about the MMS. We are going through the market strategy. That is also equally important, because out of the pocket expenditure is more than 70 in my country, including the vitamins and others. So we have to think about all these things, including the BCC package. Otherwise, all on a sudden, if you start throughout the country, it will not give us the real result.
Right.
So we plan for the next 5 years, the next sector program. Okay, year one, maybe we'll cover 20%, year two, another 20%. At the end of the 5th year, it will cover total pregnancy, maybe 50% or less. It is something like that. We are just moving from one approach to another approach. We are not totally abandon the IFA, maybe IFA plus the MMS or IFA or the MMS, something like that.
So
And
it's very nice to see you. In relation to what you just said, you're actually answering a question about the investment of the government in the public sector. Is there a budget line for MMS, and how is the government are there funds and a plan for stepping up that 20% every year over the next 5 years? How's that going to unfold, and who's going to pay?
okay, it is the, since 1998 we have the sector program, and we have completed 4 sector programs since 1998. Every 5 years there is a sector program. Theoretically every 5 years, practically every 7 years, because no cost extension for another 2 years. So we have completed 4th sector program, and we have planned for the 5th sector program, which practically will start in the January. Officially it started, but funding is not there. So in the sector program, there is an OP of National Nutrition Services. So in that operational plan, we have already included and budgeted for the MMS as well as for the IFA. So in 15 to 20% in the year 2, it is budgeted there. And other IFA also budgeted there. Next year, MMS budget will be increased, IFA budget will be decreased. In this model, we will go for the 4th year, then MMS will go for the most of the budget, IFA will get the less budget. So this is the modality we have already. By side, we are trying to involve the private sector as well. So this will be not only the public, it is private public partnership. So that is the thinking, and that is the planning. It is already included in our 5 years plan, and already with the included with the budget.
Thank you. Thank you so much, Mr.
Oh.
It's really helpful. We have a few more
Just
questions.
one point. One point.
Yeah.
In this initiative, okay, GAIN, UNICEF, I think Nutrition International, other NGOs are also equally involved to make it effective. Thank you. Over.
Great. Very helpful answer. I think we have questions coming in around methodologies and how to standardize our science around the evaluation of MMS performance across healthcare systems. And one question relates to adherence. How has Bangladesh in the pilot programs actually measured adherence? What does it mean to talk about 30% adherence? Well, actually, it was 30% coverage. So that's a different topic, a different one. But what can you say something about the adherence of women who do get the supplements once they get it? How have you measured that very important outcome? Anyone?
Okay.
Sir, would you
Okay.
like to continue?
Anyone can answer, otherwise I can answer.
So first, sir, could you please help to explain the pro-poor model adherence, how they measure? I can explain the market-based model, how we are measuring our adherence actually.
If you could explain it in 30 seconds.
Okay, go with the market. Market, I'm coming with the pro-poor.
So actually, we have developed a digital interface system so that can data is entered from our field people who is actually purchasing MMS from the pharmacies. The pharmacy owner keep record of their mothers. We collect those data from the field level to central level. The field people are entering in the system. And from those data, we analyze the purchase pattern of the consumers. And the adherence actually from the market-based model is evaluated by third-party evaluator, which is ICDDL.
Very good. That's very helpful. Thank you.
Okay.
We want to make sure that we've got questions coming in and from our audience.
Okay, the other part was the for the pro-poor. Basically, pro-poor was that in every sector program we usually go with the baseline, and the year one is the preparatory stage for procurement and other things. So by that time we have our baseline in our hand, so that after starting the intervention in the certain area, we use with the baseline and we evaluate area by area with the result what we are achieving over.
Thank you. So Bangladesh is really making progress. There's a lot of collaboration. One can only be impressed with all of the government efforts, the effort by GAIN, private industry. You're collaborating, international institutions. It really is a team effort. It takes in a way, a village to make this happen and to sustain it. Can someone boil down the most important implementation research questions, measurements that can help those around the table to think about for their own MMS implementation research efforts to advance this program? What were the most important implementation outcomes that you have measured or wish you had measured?
So for the public sector demonstration, actually,
especially the private sector, public sector one. Yes, please.
Yes, the private sector, from the private sector, what I can say that we see actually the purchase pattern, the repeat purchase pattern. I already mentioned that the people in Bangladesh are habituated in purchasing in blister forms like 10 tablets. So are they coming to purchase the second, third, fourth blister up to 18 blister? They need to complete 180 tablets. So if you see the presentation, that 18 blister purchase is up to 21%. So people are really like the MMS for their pregnancy journey. So and also from the data we are collecting from the field level, we have a dedicated telecounselors who are constantly in contact with the consumers who are purchasing from the pharmacy. So from the experience sharing perspective, we can say that the experience from the MMS, they are giving that they are feeling much better or less side effects compared to the IFA. That is very common feedback from the consumers. And also before starting the project, we also do the consumer insight study. So we know that how much money they actually can afford for this type of combination of 15 micronutrient supplements. So there are a lot of learnings. So from our side in the business model, we learn important things that how actually we can measure, because the people are coming to the counter, purchase medicine, and they go to their home. It's very difficult to measure their purchase pattern, their adherence. So it was very tough situation for us at the beginning of 1 or 2 years, how we can measure the adherence or the repeat purchase for the customer, especially for the market-based model.
Thank you. We have a number of questions that have related to how to improve targeting, how to reach women who are pregnant through the various systems. And I don't think we have time to really get into each of those questions, but the balance of interest and concern is really around how to move supplements, MMS, through the health system to increase coverage of pregnant women. And once they are reached, how to assure adequacy of the supply so that they get the dosage and the time and gestational time that's needed for MMS to, have its impact that has been seen in trials. There are issues around equity, how to reach the poorest and most needy segments of the population. Should MMS be used as an incentive for antenatal care visits, or should there be efforts to assure access to the MMS regardless of the number of antenatal care visits? These are all really important questions. Another relates to, and one of the questions was, does cost come into play with IFA versus MMS if women have to purchase, if the women are purchasing it on the market? One thing that we've seen in Jordan is that because of side effects related to IFA, women are more likely to buy supplements on the markets if they are taking IFA, and they're less likely to do it if they are receiving MMS. So these are really fascinating implementation questions that require standardization and measurement. And I think we probably need a whole several more coffee chats about just the methodology to go forward. We're running out of time, and so I'd like to turn this over to Martin for some final words of wisdom, but to also thank you for putting this together, and to our speakers for sharing their expertise in Bangladesh, which gives us all some ideas about how to move forward. Martin, it's yours.
Thank you very much, Professor Keith West. Always a pleasure listening to you, and also a pleasure listening to our Bangladeshi colleagues. As I mentioned in the beginning, it's been quite a journey working with them to try and fish out all these government documents that help us document the story of the policy process in Bangladesh. And I would invite all the listeners to download the published case study. I have to spotlight and thank our colleagues from Bangladesh for working so hard to put it together. So please download that from the HMHP website and read it. If you have any questions for them, their contacts are out there, but we can also help you channel the questions to them if you wish. Reach out to us. A lot of questions were asked. Prof did a perfect job of trying to answer them. Some were not covered. We will do our best to prepare answers. And for the questions that would need the panelists to answer, we will send them to them and forward the answers to everyone. This meeting was being recorded, and therefore we will be happy to share the recording with all the people who registered for this coffee and chai chat. This process, the policy process, we have realized that countries do really learn from one another, and they like to engage, and you can almost think of it as a peer exchange. We had the privilege of listening to Bangladesh in Jakarta in 2022, And I want to spotlight that last year we had a similar meeting of African countries in Addis Ababa, convened by the African Union and the Micronutrient Forum with other partners as well. And we are going to be having a similar meeting in Nairobi in the coming month, where we are going to also gather about 15 African countries to discuss this kind of issues and find solutions to their MMS or maternal nutrition challenges. Now, thank you very much for joining this chat. Stay tuned to for our next chat on the implementation SARS guidance for multiple micronutrient supplements. All these chats are recorded and you can watch the recording on our website. And if you'd like to join the HMHB, please apply to become a member on our website as well. And you can also follow us on X or previously Twitter, on our LinkedIn channels, and also sign up for our Micronutrient Forum newsletter. And that way you'll be able to receive all the news and updates about future webinars. Apologies for taking one extra minute. Until next time, bye-bye for now.
And congratulations to Bangladesh for its work going forward.
Yes, congratulations to Bangladesh.
Thank you.
Thank you.
Thank
everyone.
you.
Thank you very much.
Thank you.
Thank you.
Thank you. Bye-bye.
Thank you. Thank you.
Thank you, everyone.
Thank you, everyone. Bye-bye. Thank you.
Bye.
Yeah, thank you and bye.
Bye-bye.